be able to start Instagram.
Yeah, not yet, but it's coming.
You need some cool music.
I know.
Some Rivera music.
We are live, so we just had a discussion about how we need some cool music. So I would appreciate greatly all of our viewers could suggest some cool music. And I don't know how to shut off other sounds on other windows on my computer. So sorry about that. Another production failure. I'm going for a record. Hi, everybody. I'm Angie Rasmussen, and this is my wonderful co-host, Jessica Malaty Rivera. This is a special episode of Taking Shots, although I think at this rate, we're practically going to be doing it daily because the situation that we're in is really, really serious. So we have brought an excellent guest here today, our friend, Dr. Saskia Popescu, who is an infection preventionist and an epidemiologist, and is really, really great with global health security as well. So she's a fantastic expert to talk about this. I have to apologize that our other guest, Dr. Krutika Kuppalli, is at the World Health Assembly in Geneva, and it's the middle of the night there, and she just hit a wall, and we're all human. So we'll talk to her another time, probably very soon, because what we want to talk to you about today and why we think we need to have these more regular episodes of this show is that there is currently an outbreak of BUNDIBUGYO Ebola virus occurring in the Democratic Republic of Congo, Uganda, and at this rate, we're going to be having other countries, I think, involved as well. One American has tested positive and has been evacuated to Germany, along with their family, where there have been several high-risk exposures. I'm going to let my colleagues talk about the more current numbers because I was shocked to hear what the situation is in terms of the case count. And what I think people really need to understand is that this outbreak occurred last week, or we found out about it last week, but it's actually probably been going on for months. And that's really, really bad. The West African Ebola epidemic that emerged in 2013, at the end of 2013, really wasn't responded to until 2014, several months after it began. That epidemic took 3 years effectively to control. It resulted in more than 28,000 cases of Ebola and more than 11,000 deaths. So we are looking at potentially a similar situation here, except it's even worse because it's complicated by a lot of conflict and violence in the region, a lot of mobility, and a very, very large region to cover. Complicated, however, the most by the fact that the U.S. has completely withdrawn support via USAID. The U.S. is not responding. We have no really effective response plan. And historically, the U.S. has been instrumental in making sure that efforts to contain Ebola virus outbreaks are actually successful, even when they take a long time, as in West Africa. So we're in a really bad situation, and I'm going to hand it over to Jessica to fill in the blanks that I didn't talk about, but we have really, really high case counts, pretty high mortality, and we're in a pretty serious situation.
Yeah, so on the context of comparing this to previous outbreaks, despite the public health emergency of international concern declaration that happened this weekend, happening, a few weeks after, the 2014 one actually happened a few months after. But the big difference was that we were involved with the WHO, that we were, in fact, the largest contributor to the type of work that would be involved in a Ebola response. And we were on the ground quite quickly. And so I think this is actually a signal that this declaration happening this soon is also a big SOS shot to say, hey, we are not as resourced as we were before. We need to get our other member states on high alert because we previously could rely pretty heavily on the US. And I just want to tell folks who are listening here, when people, I was talking to a researcher about how the administration has done a really great job almost in a reductive way, treating things like DEI and USAID as enemies, even just by using the acronym alone, and by I think even using the acronym and separating what it actually stands for, which is the United States Agency for International Development, reduces what they actually did. And a lot of people did not know what we did. Our taxpayer dollars were involved in some of the most robust health security systems globally. We were the ones, USAID in particular, especially in Central Africa, were among the most like high touch point contacts for things like infection prevention and control, contact tracing, surveillance systems, door-to-door counseling on proper burial, ensuring safe and dignified burials that were culturally competent and kept in mind things like religious and personal practices. USAID was directly involved in that. And so the amount of vitriol that I'm seeing and the propaganda talking points that I'm seeing of anti-USAID, calling it, a large money laundering scheme and full of corruption. People just had no idea what actually made up USAID and the incredible, incredible work that they did overseas to keep us over here safe and secure. And I just can't, we've talked about this many times, and Saskia and I have probably done like all caps screaming texts about this, that this inability to understand that global health security is national security is going to be the reason why we suffer so much worse when the next one comes. I mean, you and I, Angie, were on the record many times with CNN and otherwise to say, we're not freaking out about hantavirus. We're freaking out about what this is revealing for the next one. This may not be the next one globally, but it is certainly a giant indicator of how pulling out of these systems, these multilateral units, and isolating ourselves from global security practices is going to cause people to actually die. And now, Saskia, if you can give us an update, I think you shared a case count that shocked both me and Angie since the last time we saw it. Can you give us an update on what the numbers are?
Yeah, and thanks so much for having me today, you guys. It's nice to join you. So about 3 hours ago, it was reported there's 543 suspected cases, 33 confirmed in DRC, 2 were just confirmed in Uganda, and we're at 131 fatalities. So those numbers are escalating pretty quickly, and I think that this is a mixture of both, what we do see at the pace of which Ebola can spread, but also now that we're starting to pump resources into that, and again, it's trickling, which is concerning because we know as we look forward, we're going to identify more cases. But the big concern so many of us have had is this has likely been brewing, been burning, if you will, since March potentially.
Yep.
And this, Jessica, I couldn't agree more. This is why we have USAID. This is why we invest in these international organizations like WHO. And while the US has moved to more bilateral agreements instead of multilateral, it's a little too late in a lot of ways. I mean, that's the on the ground resources that allow us to identify and communicate effectively, because this is what happens when we don't have resources in the community, but also those teams, those people not only provide prevention and detection and response mechanisms there in the field, but also communicate it back. And it's the communication piece that we're really lacking, the response and the detection. So that's where we're at. And I think it's very likely by the end of the day, those numbers are going to likely increase.
Yeah.
Even.
Did you also see that the test positivity rate was being reported at over 50%?
I hadn't seen that. That's
I had read that test positivity, which is essentially a fraction of the total number of tests that have tested positive divided by the total number of tests given. It's not an extremely precise metric, but it's a metric to help you understand, like, are you getting ahead of the spread of a disease? And when you are above 50%, that is telling you are severely under surveilling an infectious disease outbreak. You want that.
I agree with that. However, I really want to put some caution into talking about these testing numbers right now, because there have been a lot of issues with the molecular diagnostic testing that they're actually using. Initially, one of the reasons why this wasn't detected was for a couple different reasons. So I'm going to back up really quickly and just kind of mention what the environment is like in the area that this outbreak probably originally occurred. So there's quite a lot of conflict in this part of the Democratic Republic of Congo. It borders Uganda and South Sudan. There are refugee camps and refugee populations right across the border in South Sudan. In Rwanda, which is also neighboring, there have been filovirus outbreaks, a Marburg outbreak fairly recently. Uganda actually has been really unfortunate with filovirus outbreaks. So they do have this expertise in these areas, But the problem is this is a very, very large region. It is not very well developed. And because of all this conflict and violence and migratory populations, both from mineral extraction operations throughout this area, as well as, violence for political violence, there's essentially a civil war occurring in this area. It's a really, really complex security situation, and that makes it very difficult to access. So it's very hard to get samples from this area to other places. Now, as I mentioned, some of these countries around there have had infrastructure buildouts, including the DRC, including Uganda, including Rwanda. There are facilities, but it's a problem when you can't actually get the samples from where they're collected to the place where they can run them. And on top of that, the INRB, which is the facility in DRC where the samples were initially sent for diagnostics, we're using a PCR test that actually doesn't look for this type of Ebola virus, because Bundibugyo virus is a different species of Ebola. So there are 6 species of Ebola viruses within the genus Ortho-Ebola virus. Sorry, guys, we're going to talk about Linnaean taxonomy for 2 seconds. I hate it as well. But there are 6 species of Ebola virus. 4 of them can infect humans and cause disease. Only 3 of them have ever caused outbreaks. There is Ebola virus, that's the OG Ebola. There is Sudan virus, which recently reemerged in Uganda, and that outbreak was contained. And then there's Bundibugyo, which has only ever emerged twice before. But because they are different species, this is like looking at a house rat from Europe versus a house rat from North America. Same genus, they're both rats, but they're different species. So, you're talking about something that's very similar. It's Ebola, but it's not Ebola virus. It's different enough that it won't show up on a PCR test for Ebola. And that's fine. I mean, you wouldn't expect to actually see Bundibugyo virus because these outbreaks that it caused before, the only 2 times it's ever emerged, have been extremely small. This outbreak is already 10 times the size of those earlier outbreaks, and it's moving up to 100 times the size of those earlier outbreaks. So this is a virus that we weren't looking for simply because it was so rare that we weren't sure that we would need it. And it was detected using metagenomics, so sequencing, as well as another type of PCR test that is a panfilovirus test that can recognize multiple ones of these. Now, the problem with tests like that is that they are more prone to false positives. And I don't actually know what the numbers are on that test. So this is why that's a very long way of me saying that I want to be careful commenting on the testing situation, because it's been complicated both by just the circumstances of the situation and these many security issues and the challenges with access. But it's also complicated by the fact that, frankly, we just don't know that much about Bundibugyo virus. We haven't invested that much in it. I've done a little work writing it into grants and things, but even though I've worked with Ebola viruses extensively, I haven't actually done an experiment with Bundibugyo virus, just because you don't really need to when it's not emerging very often. I mean, you'd like to be able to study all the viruses, but there's limited resources. So you prioritize the ones that are actually known to emerge frequently and hurt and kill people. Yeah. For that reason, we have to make a lot of assumptions about the unknowns about Bundibugyo virus, because we just haven't really studied. It's never caused something like this. And I don't think it's because, and we know from sequence data that has come out, that it's not a very different Bundibugyo virus. It's not some new variant. This is entirely circumstantial. And this is because of the complexity of the situation, but it's also because of the withdrawal of money. Yeah. So talking to clinicians, to our colleagues, and I wish that Krutika was able to join us tonight because she knows about all of this. There were extensive efforts to train people in the DRC, in Uganda, and now in Rwanda to deal with these outbreaks. But even the best trained people can't show up if they're not being paid to do work, and to do work that actually is quite hazardous, both from a security point of view as well as from a biological point of view, especially if you're not going to give them adequate PPE because you can't afford to buy any. And especially if you're collecting samples to do tests that you don't have reagents to run and that you can't get to the lab that does. So the problem with USID withdrawing is not just that they're not communicating stuff and doing surveillance. It's that they are not capable of responding, despite the fact that we've spent millions and millions, hundreds of millions of dollars investing in these countries so that we could be prepared for this. And that's what we should be doing with global health. And that's what the US has chosen to just abandon. And now we're about to see the effects of that.
Yeah, I
Well,
mean,
Angie, I think
go ahead.
Go for it. No, go for it, Jess.
No, go ahead.
I mean, we're probably both going to speak to a little bit of response, which is kind of the big challenge right now. So I did want to note, Angie, to your point, I mean, it's still Ebola, but I know already I'm seeing conversations in infection prevention channels of what do we need to do differently to prepare? Does this require like everything from different disinfection protocols? The PPE is the same, right? So it's already starting to throw a little bit of a wrench into this. And that's what happens when we are caught off guard. But also, I think a lot of people have probably seen the State Department has been putting out information, and now the goal is to throw a ton of money, well, not a ton, but a drop in the bucket compared to, I think, what, it's a little bit too late. I think if we would have kept USAID, it probably would have been cheaper, but nonetheless, the goal is to really set up these treatment facilities. But, you've got Jess and I on here, who is epidemiologists, will always tell you, treatment is so far down the line. You need to absolutely invest in that contact tracing, that PPE in the field, because one of the challenges I'm consistently hearing is like when we identify cases and we don't have the PPE to properly transport care, et cetera. I mean, that is extremely dangerous, but you're also really limiting what people are willing to do because they're scared for their lives. So I think we're going to consistently see this challenge of like, let's throw a bunch of money at building all of these treatment facilities, which is important. We want those, of course, but let's make them sustainable so that when we're not doing what happened in 2014, 2016, which is when the US pulls all their resources out, as well as other countries, we're not leaving people in this situation of kind of cleaning up the mess without the people and the resources to maintain continuity of operations. So what I really worry about right now is like, it's a little too late, and we're focusing on part of the problem and not the whole problem, which is absolutely the epidemiology, the quarantine, because this is such a big piece. As we do contact tracing, you are asking people to do monitoring, daily health checks, really staying home and quarantining. And what does that look like? Because I think we all remember, just even with COVID, staying home is not always possible if you need to feed your family. And asking people to do this when in this emergent situation is not an easy task. And are we giving them the resources to do so? So sorry, Jess, all you.
No, if you're running from also like literally a war, I mean, people who are in conflict zones don't stay in the same place if there's active conflict occurring, because that usually means like killing people. So they move, understandably.
Well, and also just for reference,
one of the biggest challenges here, because now we have cases in multiple major cities in the DRC.
You mentioned refugees. It's not just a couple of hundred. Some of these refugee camps have thousands, tens of thousands of people. So this is, I mean, and we all know that the living conditions, the health conditions in those environments are not ideal. So this is a disease that spreads very efficiently in close quarters where people do not have adequate access to hand hygiene, to cleaning and disinfection. And that's something that really, really worries me. But all you, Jess.
The idea of an Ebola outbreak in a refugee camp is something that everybody should have nightmares about. I can't imagine something that would be, a greater humanitarian disaster that we could have prevented.
Yeah. I mean, and just to like lean into the epi of this all, there's quarantine, but then there's also isolation, which is different and requires a whole lot more healthcare infrastructure to have proper isolation. And you're already dealing with a place that is under-resourced, that does not have the healthcare infrastructure to have, perfectly safe and separated isolation wards. You're talking about people who are like at best getting masks on, at best putting curtains up to separate confirmed cases, because you're dealing with, again, an area that is, because it is a mining area, because there is so much traffic, it doesn't have a lot of like residential infrastructure. And so you're not dealing with people who could just go to their homes, or even hospitals that have multiple rooms to do that. That's why these kind of temporary clinics would be helpful. But again, you don't, we use this metaphor a lot in public health. You don't build the fire station when the city's on fire. You create the systems in place with the network of water and the fire hydrants and the trucks that have gas and have ladders, so that when you respond, you are not late to the game. This is very much, putting a Band-Aid on a hemorrhaging wound. A terrible metaphor here, but like it's so far gone what this actually is. And to compare this, in 2014, because we had systems in place, it still required almost $1 billion with a B dollars of spending within about 6 months. It required a deployment of over 3,000 military personnel from the U.S. military, hundreds of people from the Centers for Disease Control and Prevention. It was one of the largest deployments they've ever done, and they built multiple clinics at that time. And one of the things that they did is they trained people there. We don't even have a healthcare workforce there that probably can even do that type of training right now. They're just in triage mode, So like, you're going to be coming in to an actual mess and saying, oh, we have this, what did they call it? An ironclad commitment. An ironclad commitment would not tear down the infrastructure responsible for the prevention, the detection, and prevention of a catastrophe like this. It is truly out of control at this point. And even if we are very unclear about some of the testing mechanisms and the results there, we can all say pretty confidently that what we're seeing is an undercount, and it's much larger than we have visibility on.
I couldn't have said it better about the count. What I am really, really concerned about is just how large this outbreak is. And both of you, I'd love to hear your perspectives, because I'm not an epidemiologist, but I do know a lot about Ebola pathogenesis, or the process by which Ebola causes disease. Bundibugyo, at least in animal models, proceeds on a similar track. And with these numbers, and what I know, at least, and again, we don't know that much about how quickly Bundibugyo can spread. We don't know if it's more infectious than Ebola, but I think there's actually some scientific reasons why it probably isn't that much more infectious than Ebola. It may actually be less pathogenic, because the previous 2 outbreaks have had a lower mortality rate. However, I don't think that those outbreaks have been big enough to accurately assess the mortality rate. And we have seen with Ebola virus, vastly different mortality rates from one outbreak to the next. So I don't put that much stock in that. But I don't think we have any evidence anyways that shows that Bundibugyo is a much more transmissible or contagious virus. What I think people don't understand about Ebola is that it doesn't actually kill people as quickly as they think. I've had a lot of people ask me, well, the reason it can't cause a pandemic is because it kills its host too quickly, and viruses have to have a host, so it can't spread. That's bullshit, because one of the most common ways to contract Ebola virus is to handle dead bodies of people who died from Ebola. Early on in the West African outbreak, one of the ways that it spread so broadly across the region is that people in border communities of the 3 countries, Sierra Leone, Liberia, and Guinea, were going back and forth across the border to people's funerals who had died from Ebola, getting Ebola from the body that was being buried and bringing it back to their community for more funerals in the future. And so body and corpse disposal is an incredibly important part of Ebola containment efforts. And actually, again, USAID and actually NIH to a degree, because NIH has funded a lot of collaborations to build infrastructure to do things. So even though that's not as involved in corpse disposal, they're able to identify people who died of Ebola from people who died of other things. And one reason that this may have also been undetected is that it may have been confused with malaria, which is extremely common and shares many symptoms in common with Ebola. Now, another thing about Ebola is that people think that it's like in the hot zone where there's like people weeping blood and like all this blood everywhere. And it's like, you know, the movie
like Outbreak. Come on, it's
I mean, Outbreak is a great movie,
Obviously,
but it's not because it's so accurate of a depiction of Ebola virus disease pathogenesis. Love Outbreak, but Ebola is not going to go airborne, and there's good biological reasons for that I can talk about another time. But ultimately, what it comes down to is that Ebola virus can spread. very easily. It's not going to be by the airborne route. And for that reason, it can't be transmitted from person to person easily by the airborne route. It won't evolve to do that. There's, again, good biological reasons for that. But that doesn't mean that it's not extremely transmissible. When you have other diseases like malaria that it can be confused for, people aren't diagnosed, people die of it, and they don't realize they've died of Ebola, and more people can get infected. And so there are lots and lots of ways that are circumstantial that work with the virus's biology to allow a huge outbreak to occur. And even if it's not a pandemic risk, as you said earlier, beautifully, Jess, and I know Saskia will agree with this, it's essential to global security to make sure that we are not letting these outbreaks turn into effectively humanitarian disasters. And I'm afraid that that is actually what is about to unfold before our eyes. And it's hard for me as an American not to say that I can put most of this at the feet of the US government, because
100%.
It might not have been detected, soon enough. We might still have to deal with an epidemic, but we'd at least have a plan to deal with it. I mean, right now, we heard, I called in to the CDC press conference. A reporter gave me credentials and I called in, and it was 15 minutes of being told vague specifics that really the only piece of information that was shared was that there's a positive American and they're being sent to Germany. And apparently now they're at Germany at Charity Hospital, which is a perfectly adequate facility for them to be in. There's a travel ban now for everybody from these countries, which is completely useless because we're not even letting Americans back into our country.
No.
We have a demonstrable track record of being able to take care and, save the lives of Americans who've gotten Ebola, including some of my friends and our colleagues. We know several Ebola survivors who have been given very good care in the US. And our national plan is basically like, ew, we don't want your Ebola. I mean, it's like Trump's 2014 tweet that everybody's, a lot of people have pulled this out, where he's like, they're letting Ebola people back into the US.
The borders.
We don't want them here. Like all caps. I mean, now it would say probably, thank you for your attention to this matter. But President Donald J. Trump. But I mean, that's what it is. It's like, keep your Ebola out of our country. And I mean, we're turning away Americans now who need help, even though we could help them. We're just not going to, because Ebola. That is the dumbest, first of all, strategy for public health. But it's also incredibly frightening, because what if it was you? Like, the US just decided that we don't care about Ebola. It's not a problem.
Well, Angie, I think it's kind of like, to me, it's a little bit of extra of a gross irony, because it's like, we're going to pull out of WHO and a lot of our international agreements and norms. We're going to do our own thing. You guys are on your own. We'll take care of ourselves. And then when this happens, I mean, a lot of people were wondering, was this American physician so sick that he wasn't able to transport safely to Nebraska or to Emory? Possible, but it's more and more sounding like kind of we just didn't want to take him. And I think the irony of that is so breathtaking to me, because it's kind of like, we have all of the capacity, the resources, we have tested and invested so much into this system to be able to handle patients with high consequence diseases, and yet we're just going to be like, actually, Germany, can you take it, because we don't really want to deal with it. After all of that is such a slap in the face, I think, to the global health system, and right now, especially during the World Health Assembly in particular, I cannot fathom what that is like, because I always tell people, every outbreak is different. Even with pathogens we have a lot of experience with, every outbreak is very, very unique, but our ability to keep screwing up the same way is pretty tried and true at this point. And that's the part that I cannot understand at this point. It's like, travel bans, we know that those don't work. We genuinely know that. And I'm also very curious to see what the plan is with, we have this big thing called the World Cup that's going to start in the next month or so. And I'm very nervous also, because we know with travel bans, there is an amount of racism and xenophobia that comes into play. So coupled with ICE,
is the Congolese national team going to have to forfeit their match in Houston? Because
are they going to be testing them? Because that's the thing that would worry me too. Are they going to make them go under a quarantine or some random Ebola testing for some reason? Like, this isn't COVID. And it's all of those things that I think really are just shocking, because I don't know how you two feel, but when we saw the hantavirus situation unfold, I was like, wow, there's actually like some pretty significant global effort around this. WHO swooped in and really helped to coordinate everything. And it felt like, at least for the most part, there was a pretty good job about how to handle folks, disembarking. And then this happens, and it's just kind of like, same shit, different day.
Saskia, do you know why that is with hantavirus? Because even though there's a lot of uncertainty about hantavirus, which I gladly acknowledge, I actually know more about hantavirus than a lot of the newly minted hantavirus experts, because at least I have worked on it a little bit. And I know enough that I know how little is known, but we do actually have quite a lot of evidence, as both of you can attest, that hantavirus, despite many people's statements to the press in recent days, is actually not that transmissible from person to person, including by the aerosol route, except in very specific scenarios. For example, a crowded birthday party, or a cruise ship, or sleeping in the same bed.
Which is the definition of close contact, in case anyone wants to know.
Yeah. So, the WHO response was heavily criticized by some of these, hantavirology experts. And
I call them tourists.
I thought, the tourists, essentially, commenting on everything from molecular diagnostics to virology to minimum infectious dose to even talking about how viruses are measured. Guess what? We don't use PCR to measure infectious viruses, guys. Learn about the plaque assay. Anyways, as Jessica said earlier, we were all saying that this is actually a warning. I think that the WHO response was exemplary for hantavirus because it's not that transmissible. WHO proceeded to coordinate global responses to a virus that was appropriate for what we knew about it, and that accounted for the fact that it was an unprecedented event. It was how it should go. But the WHO is not able to do that in the Democratic Republic of Congo because Ebola surveillance and Ebola outbreak responses were coordinated by the WHO in very close partnership with the US. Because historically, the US and the CDC in particular has been the world leader on determining how to deal with Ebola outbreaks. They have more experience, and now other countries where Ebola outbreaks have occurred have been trained. So there's a lot more global expertise. But really, when Ebola outbreaks started happening in the 1970s, the US was very heavily involved, and specifically the CDC. The US invested a lot of money in research for these high consequence pathogens. We learned all about biocontainment. We learned how to basically deal with these pathogens that are really, really dangerous, that don't have vaccines or treatments. And by the way, what I said earlier about diagnostic testing also applies to vaccines and monoclonal antibodies. The ones that we have available for Ebola virus will not work for Bundibugyo virus because it is a different species. It is not a variant of Ebola. It is a totally different Ebola virus. So even though it will act like an Ebola virus, it's not the same as Ebola from an immunological perspective. Yeah. So we have nothing for this virus. And the US has been the world leader in doing research on and containing outbreaks of this. The Epidemic Intelligence Service, which both of you know a lot more about than me, has really pioneered and developed the methods for responding to this. And now, we've gotten rid of all that. First of all, the CDC isn't a functional agency any longer. And we're just going to sit this one out, and we'll give you a few $1 million and we'll build these dumb clinics. And that's
I think since we've been talking too, State Department Secretary of State Rubio made a comment, I think since we've been talking or just before, noting that WHO was late to the game on Ebola. And I just want to say, I think, first of all, it's a really disappointing take. I'm trying to be really diplomatic with this. But
I'll say it's fucking stupid. Lil Marco, he's got some audacity to say that, but that's also exactly what I'd expect him to say.
Well, and I just want to remind people, we willingly left WHO. There's discussions around how to stay on with some relationships, some tracks, but we also, I think, still owe $250 million in dues. So it's not just that we've walked away from the table on that. But then to say that they dropped the ball on this, like, look, there's a lot of detection. This is a really, really challenging, to your point earlier, Angie. Like this is, and I think Jess, you said it too, that this is a really complex environment for identification. There's a lot of moving pieces with testing, but also these are rural areas. And there's definitely delay in detection and reporting, but
There's no
to say the
roads.
WHO dropped
I mean,
the ball on it, I'm quite surprised by it, because if you look at the notification pathways, like they responded, and this is declaring a public health emergency of international concern this quick. I think everyone was like surprised by, but also very pleased by, and it's
that was
and
unprecedented
that's
too.
yeah. It's just I asked myself, how does this help the situation? Sending money to build treatment facilities, great, you get a gold star for that, but that is not remotely everything that is needed, and then dunking on them is not helpful in the process.
Well, what are
Right.
these treatment facilities? It's going to be a bunch of ETUs. I mean, we did that
Mhm.
before. They're going to be temporary. They're going to be horrible for the patients who are in them. This is a drop
They
in the
take
bucket.
time. They take time. They take weeks, if not months, to put
Yes.
together.
Yes.
Like
This is
that's the thing that's crazy.
This is the exact thing though that I mean, you're telling me that the Trump administration didn't pay its bills to the World Health Organization. I can't believe that. And you're telling me that they're just like making shit up. And you're telling me that they're darvoing everybody and gaslighting everybody about how great the response is when it like obviously sucks. I mean, this is the same old MO. And this is the problem with everything. It's like, oh, same shit, different day with this clown car, except this is a fucking Ebola outbreak. And like, we are going to see potentially more people getting infected with this virus and potentially dying from this virus than we even saw in West Africa. And I don't want to be alarmist. I'm not trying to fearmonger at all, but I'm seriously concerned that that is going to happen from a humanitarian and a global security point of view.
No, absolutely. I mean, there are several people who are former employees of these agencies who are saying, we know how to do this because we've done this before. This is the 17th Ebola outbreak in DRC. It's not the 17th for Bundibugyo, but even still, there is protocol here. There are standards because of all of the historical data that we have, because of all of the experience we have, that really effective contact tracing systems need to be in place, that really effective communications programs need to be in place, that really effective, in the context of Zaire, like ring vaccination, like we have systems in place to know exactly how to control an outbreak. And right now we are just throwing a drop in the bucket and saying that'll do it, to only do one thing, in my opinion. It's just to alleviate any sort of guilt or responsibility that the US might be feeling right now. This unpaid due is so severe because if they paid it, it would actually make a meaningful impact on this outbreak. Because we know from the previous one, at least $300 million would go straight to the immediate response. And it wouldn't just be like building clinics. It would be doing exactly that. It'd be making sure that there's continuity of healthcare staff, because as we mentioned, the people who are probably getting exposed the most are healthcare workers and people who are managing the dead bodies, people who are burying the bodies. We need to make sure that the healthcare workforce has a contingency plan, that if that front line gets sick, that there's second in command and third in command, and that you have systems to take care of those people so that they don't succumb to the disease themselves. So it's deeply insulting, from like an even historical standpoint, to know that we've done this before, we know exactly how to do it, and then they come up with this statement that says, here, we'll just throw $13 million at it and build 50 clinics. Like, nobody asked for this.
Well, we owe $260 million from
it's
unpaid dues in 2024 and 2025.
It's unbelievable to me. It's almost like they're trying to like negotiate a credit card bill and be like, but I only have $13. Can I just pay $13? Like, no, this is actually a legal obligation that they have. I mean, these are contractual agreements. I mean, the whole purpose of issuing a PHEIC, a fake, which I hate pronouncing it like that, a public health emergency of international concern, is that you have these relationships with member states that require them to follow the 2005 international health regulations. Those are legally binding agreements that member states, the over 190 countries that are members of the WHO, would be responsible for contributing to the things that we just mentioned: surveillance, contact tracing, reporting, infrastructure support. And here we are, the largest contributor historically, absent from the table, and telling them you're not doing a good job.
Yeah, you guys are doing a terrible job, and we're doing so awesome. It is just amazing.
How can they be
I don't call it a
America
fake,
first
though.
too?
I call it a feek.
Say it again.
I call it a
I
feek
say
too.
feek. I mean, like kind of like
feek or
freak.
fike.
Like I'm a freak
Feek.
because I can set it to Cardi B lyrics. I entertain myself by listening to empowering female rap artists, and I sometimes make up public health related lyrics or complex related lyrics. I listen to it oftentimes when I'm not feeling my best, and I need a little like positive energy for the conference that I'm going to, and hopefully not create drama, but like impress everybody with my scientific prowess. And so feek sounds like freak.
Honestly, Angie, for me, the song was Rihanna, Bitch Better Have My Money for this one.
Honestly, I
mean, that's certainly on topic.
I see for all the, go ahead.
Shannon's got some questions in the chat, so I just want to make sure that we answer those.
See, I'm such a bad producer. Sorry, Shannon. Thank you. Survivors can spread it sexually for months afterwards, right? Correct for Ebola virus. We don't know about other filoviruses. I would imagine that persistence would occur. I don't see the mechanism of persistence in the testes is not well understood. It's not understood why virus will be transmitted months afterwards when people have been getting into transmission potential situations the whole time. There's certainly RNA in there, but it's not clear if infectious virus is always being made or if it's just made sometimes. And if it is just made sometimes, what triggers that? It's not a herpes virus, so there's no obvious mechanism for, reactivation or going into a lytic state. We just don't know. So it's certainly possible that survivors of Bundibugyo virus could start new outbreaks, because that has happened with Ebola virus years sometimes after they recovered from Ebola because of this persistence. But it's just not something we understand very well for the one virus that we understand it for. And I will add that, it started to be kind of suspected. There were like anecdotal reports of maybe this could happen. But it wasn't until there was a big enough epidemic, West Africa, that there were enough people that this happened in that we were able to identify this as something that happens. So that's one thing for people to keep in mind. We don't know a lot about these viruses sometimes and what they might, do in the human population and how they might be different from other viruses until they actually infect enough people because of an outbreak of this size that we see what happens in a diverse human population. So, a lot of these things
we invest in research too.
Yeah, we can take the information that we have from the research that we invested in. We can take it from the previous outbreaks that have happened. And we can take it from our knowledge of Ebola and other filoviruses, Marburg, but biologically, filoviruses are actually somewhat different in terms of Ebola and Marburg. So, we have information, and that's what we're going to use to do the best we can. We might not get everything right because we just don't know that much about this virus. Yeah. And that's why it's so scary that it has spread so widely, because, okay, great, we're going to get to know more about it, but this is not what I'd prefer. I'd actually prefer to be left in the dark about what this virus is going to do if it gets into thousands of people.
Yeah. Can I share an unpopular opinion here? Because I do feel like we're kind of losing the plot here on public health in the US, where, they're very captivated by a disease that reminds them of Hot Zone and Outbreak and very dramatic Hollywood depictions of hemorrhagic fevers. And we're very interested in a cruise because it's kind of signaling back to COVID days, and rats are gross and rodents are gross, etc. Right, exactly. And there's a lot of it's over there, we don't want it over here, which is incredibly ironic that people who are anti-lockdown are being lock those people in a boat prison or lock those people, on that continent. That's neither here nor there. We have a mass gathering event happening, like you said, Saskia, very soon. Why aren't people realizing that the more imminent threat to them is measles? Are other vaccine preventable diseases that are probably going to pop off in the US because the US is the largest exporter of misinformation related to vaccines, and vaccination rates around the world are dropping. So I would not be surprised if we, in the next few weeks, as the games begin, we are dealing with our own homegrown problem of imported infectious disease
Absolutely.
outbreaks because we've lost the plot on what it actually means to like be good global citizens and public health partners. I mean, that's where I'm losing sleep right now. I'm not worried about everybody in America getting Ebola. I am worried about us not having the systems in place to prevent the most preventable vaccine outbreaks that we know how to prevent.
I'm worried about, yeah, exactly. I'm worried about the thousands to millions of people who are going to be impacted, including millions of Americans who are going to be impacted by the totality of the destruction of our public health agencies, our national immunization program, and our commitment to global health. And Saskia, I think you probably can explain better than any of the three of us how this seriously damages our national security as well.
I mean, and I think this is the irony when we talk about global health security, people tend to forget like the security pieces in there, because what we do know is that, and I could probably spend an hour talking about this, I teach an entire class on it and I won't do that today, but the moral of the story is like our critical infrastructure, whether that is water, power, military force readiness, everything, food safety, food security, all of this is impacted by infectious disease. And that doesn't need to be this like big, Jessa, I couldn't agree more, like this big, scary, looming, emerging infectious disease, but something as simple as an outbreak of like Campylobacter at a poultry processing facility. You know, we've seen it everywhere. And I think the irony in this is just like, it's not just vaccine preventable diseases, but you know, people love leaning into the notion that like disease knows no borders, and that's entirely true that infectious diseases don't, but some borders are more porous, and you've both heard me say this ad nauseum. Some borders are more porous or robust and resilient than others, and what we do know is that willingness to invest in global health also means domestic health.
Yes.
And it is absolutely our domestic global health, or our domestic health security, public health, all of it is reliant on global health and global health security. And the more we say like that's a you problem, becomes an us problem. And it literally impacts everything, whether truly, because I was just at a conference and we were talking about antimicrobial resistance in conflict zones. And the biggest thing we have to remind people is like, hey, soldiers come home. They're still people in boots, and they come home and they bring those resistant infections home. And it's something as simple as that. So
Sorry, it's just me like not knowing how to do things on the production software. I apologize. Shannon, thank you for the comments. I'll get back to you.
We appreciate you, Shannon.
No, seriously, Jessica has kindly offered to give me old lady lessons on how to use Instagram on my phone.
I need lessons too.
Like, yeah, I mean, I am so I'm the greatest middle-aged influencer in the world. Here, I'm going to do Trump administration thing. You guys all suck at Instagram, especially you, Jess. And I am amazing at it. I'm going to be the best influencer that has ever existed, despite the fact that, you know, I'm probably going to spend way too much time making reels about my perimenopause symptoms.
You know, it's deeply relatable content, though.
It is. I mean, at this rate, you know, just throw another fucking thing on the pile. Like I just can't get enough.
No, really.
You guys, this has been fantastic. We've been on for almost an hour. Do you want to go for the full hour, or do you want to wrap it up? What do we want to do today? I think one thing I wanted to bring up, and Jessica and I had talked about this a little bit before, is we're thinking of doing just a brief little daily update that you could tune into. That's, you know, 15, 20 minutes kind of thing, where we're just kind of talking about the latest and not greatest with this situation, because it seems like there's new pieces of information coming out every day. And with the way, you know, as we've just been discussing, if this is discussed in the wrong context, and if people get this information in the wrong context, it really paints a misleading picture of what the risks to this situation really are. And I think that's one of the things that the three of us wanted to kind of discuss today, is to put this in the proper context. This is a huge deal. The problem is I'm not losing sleep over, am I going to get Bundibugyo virus? I'm not worried about that at all. I'm worried about all of the people that are going to die from Bundibugyo virus. And as you were just talking, Saskia, I was thinking about 2018 and some of the comments that I made to the press then about the Ebola outbreak that was occurring in the DRC in North Kivu province, which has a lot of similar features to this situation where there's, it's conflict, it's a war zone effectively. There were a lot of security situations and challenges with access. And I would say, the DRC has a lot of problems and it's very difficult to deal with this, partly because they're also having epidemics of preventable diseases like measles. And now, can't say that anymore from the US or Canada. We are also having these preventable epidemics, and it's not because, the vaccines don't work anymore. It's because we're not using them. And it's because of disinformation that demonstrably harms people in countries where these diseases have been eliminated. We should have a completely measles-free public health fighting force ready to go out and address this Bundibugyo virus outbreak. Literally, our pandemic preparedness plan was not necessarily maybe the optimal one, but this is the kind of situation that we funded this type of research for. It was to prevent a virus like this that we know is potentially dangerous, killing a lot of people, whether or not we're actually going to get it or not, because we understand that this is a global world and we will be affected whether or not we're infected by this virus, will be affected and impacted by the results of an outbreak or an epidemic. And that's what, unfortunately, is about to unfold in front of all of us.
Yeah. It's going to get worse before it gets better. Somebody asked in the chat, did we cover how far away we are from the vaccine? Years.
Yeah.
It will not be in time.
There's nothing. There's preclinical stuff.
Exactly.
But I also, Liam's question here too, I think is a really important one about, does the healthcare worker case indicate it's moving faster? I would not personally say that indicates it's moving faster, but we do know healthcare workers are at the highest risk.
Yep.
But anytime you're coming into close contact with blood or bodily fluids, so that's also, Jessica brought up a really important point about safe and humane burial practices too. That's why when we saw such high cases of family members, it's because they were caring for the individual who was sick, but also then taking care of the body post-mortem. But healthcare workers, to me, and I say this as an infection preventionist, not to be callous, but when those infections occur, it's not particularly surprising because of the work that we're doing. And that, we do know that when someone's taking care of a patient with Ebola, they're as close contact as they're going to get. Usually the patient is very, very sick, and that's when they're at the highest viral load. I totally defer to you, Angie, on that. But I also want to note too, in these outbreaks, when they are occurring and you don't necessarily know what the patient has, because sometimes these can be really non-specific symptoms like vomiting and diarrhea and fever, that's not going to automatically tell the person to put on Ebola PPE. That's really non-specific. So that's why you often have healthcare worker infections very early on, or in rural areas where they're just taking care of everyone and they're not automatically thinking of Ebola, and they're not automatically putting on that PPE, assuming they even have it.
Yeah.
I wouldn't expect to, if I were a healthcare worker and somebody came to me with fever and maybe some nausea and maybe a little jaundice, it might be Bundibugyo virus.
Yeah.
I wouldn't think that, in this region, everybody gets malaria. If you don't have antimalarials, malaria is incredibly common. There's other things too. I don't know how much yellow fever there is in this area, but I'm sure there's dengue. There's other things that can cause hemorrhagic fever, viral hemorrhagic fever throughout Central, Eastern, and some parts of Western Africa. There's a number of viruses that can cause it. There's a number of other pathogens that can cause it. And sepsis also causes some of these symptoms. So it can be really difficult to figure out that this is even an Ebola virus, much less, this is the one that the name I can't pronounce. We don't know. Jessica and I had a whole debate, or was it was me and you, Saskia? Or was it
me and you?
No, it was me and you. Jessica, about how do we pronounce the G? We've both heard it both ways at filovirus meetings.
The hard G.
I've heard people
You're hard G.
pronounce
I'm
it.
hard G.
I'm hard
I'm
G.
soft G.
Yeah. See, I
Okay.
always back to my
Soft G,
business
soft G for Bundibugyo, hard G for Gizaid. Try pronouncing that one with a soft G.
Yeah, I mentioned Gizaid like at a meeting recently, and everyone was like, "You mean?" I was like, "No, hard G on that."
I mean, honestly, I should just use soft G. I should just be unashamed of it. I try to be professional, believe it or not. But yeah, I've heard it pronounced both ways. Including
I'm going to start calling you Angela.
Yeah, you can call me Angela Rasmussen. The German pronunciation.
Exactly.
Oh man. Yeah, I just, I like the more chic French pronunciation. I have no idea.
It does sound very chic, I'll give you that.
I have no idea locally, because it is the name of a place in Uganda. So I guess we'll have to, the next time you go to Uganda, Jess, can you ask some locals how you pronounce the word?
I mean, I've heard it with hard G in East Africa. So, but it's, again, it depends. DRC is a French speaking country. It could be soft G there. So, neither here nor there. We know what we're talking about. It's that virus. It is the unique one from the other types. And,
Yeah, exactly. It's the stupid one that now I'm going to have to say the word all the time. And I'm like, potato, I guess, like, whatever. I'll switch to the hard G if somebody tells me authoritatively, like that's
see how it feels.
Yeah.
But I feel like it could, people call me Rasmussen constantly and I don't freak out about it. So it's all good. I'd be like, no umlaut, dude. Like Rasmus. Anyways, this was great.
Anyway, well, this was great.
And I think
thank you so much for joining us.
Thanks
Jess,
for
do you
having
want
me.
to try out I know before I was like, whoa, I probably won't start it tomorrow, but do you want to try our first update chat tomorrow morning?
Let me look at my calendar because it is popping off right now and I will keep you posted. But yeah, I do think even if we did a 10-minute situation report every day would be great. So
I'll throw this out there. I will show up and do that no matter what. And hopefully Jess will be with me sometime tomorrow morning, Mountain Pacific time ish. So not too early, but maybe later morning on the East Coast.
Yep.
Happy hour in Europe.
Still staying hydrated on all these.
Yes, unfortunately. And I was doing this thing that we're going to be doing more of also. So this is an adjacent topic show, the Ebola Expert Roundtable. I don't know what Dr. Celine Gounder, who's organized it, is going to call it, but she's assembled a group of the Ebola Avengers that we're going to be participating in. That's going to follow up on a roundtable that we did last week, and we're going to start doing it weekly. And that's going to include Krutika, our guest, who was too tired to come today, understandably, as well as a number of other people who've actually been responders to Ebola outbreaks. Craig Spencer, who is an Ebola survivor himself. So a lot of people with really deep expertise. So we're going to be continuing to come at you with all of our expert friends to keep talking about this because we really do think it's super important. And, hopefully Jess and I will be there both tomorrow to just, drop a little hot, Bundibugyo gossip.
Sounds great. Thank you both again. And we'll see you guys probably tomorrow.
Yes. Thanks, everybody. Don't forget to follow us and subscribe to our Substacks. Ladies, stick around for a moment until the stream ends. Sorry to do this production stuff, but I can't trust myself to be competent with this. So just hang tight. Bye, everybody. We'll see you